By the people, for the people. The Gathering to Get Healthcare Now, Chapter 23. Affinity groups, clinics, and cooperatives. Each time a group of people come together in associations or work groups, the thought of using group purchasing power to reduce personal and business expenses is promoted by the members and by outside vendors. In the case of IPAs, the most common attempts to use their purchasing power are in the areas of professional liability insurance, medical insurance, property insurance, medical supplies and equipment, and staff leasing services. Large physician associations that are sponsored by hospitals have been in the forefront of this. Affinity products and services offered for many years. Consequently, it's very difficult for a small IPA to offer such products and services in competition with those offered through the larger associations. Individually, many physicians willingly and unwillingly provide free care to patients. When indigent patients come through the emergency room of a hospital, physicians are sometimes reimbursed at Medicaid rates by the hospital. Religious-based hospitals in some areas have some compensation policies regarding physician reimbursements, but most hospitals have no payment policies. Since there's a very large percentage of the population that has no insurance and can't pay large medical bills when the bills come unexpectedly, there's much bad debt accrued. Private employers think they're paying for doctors and hospitals' bad debts through higher premiums, and the government thinks it's paying through Medicare and Medicaid programs. Doctors think they're just getting hammered for no good reason. It's a peculiar system that looks very much like taxation without representation, in that there are laws against refusing people emergency medical care, but no laws about payment for the services. The failure of payment could be interpreted as a form of taxation of the population that is licensed to deliver medical care. Historically, there has been a failure to provide a reasonable means to pay for care. Some limited thought has been given to the reform. The payment problems addressed through PPACA, the new health insurance law, are still wrong, and reform of this law is blocked. The true nature of the problem is not understood at all by the medical care providers or by the money handlers. Solutions to healthcare reform and payment are outside of our system of government and outside of the economic models that leaders understand. The correction could be in the hands of the people who suffer most from the problem, patients. It's likely that the economic system that would address the problem is Paracon, participatory economics. Paracon in this case would mean that patients form and govern cooperatives through which they can hire a contract for appropriate medical services, effectively doing for themselves what they want government to do for them. The sayings from Peter Moran in his easy essays are now true, that people in the past said of the Christians that they took care of themselves at a personal sacrifice, but now they pass the buck to the government. Of course, Peter Moran was living through the Depression and helping feed people in soup kitchens in New York, and did not see much positive in what government had done in his lifetime. The difference between Peter and most of us in this time is that Peter did something every day at a personal sacrifice about the problems he saw. Patient physicians cooperatives can be created in which everyone gets care. It would not seem so easy if the amount of money for primary care were not such a small percentage of the premium dollar, less than 10%. It means that people who thought they could not have access to health care because they did not have health insurance can afford to pay for primary care using a few hours of minimum wage labor per week. even if the folks with signs who stand on the corners in the cities can get enough money to participate. Organizing cooperatives is not as difficult as grassroots political organization. Cooperatives are based on common wants and needs of members for better access to health care. Since no economist, state, or federal government has yet addressed this access problem well enough to solve it for all of its systems, no competing system has been created to limit the formation of community-based cooperatives. Such entities can become insurance companies, as has happened in the past with farm cooperatives and fraternal organizations, but until they want to pool their money and buy healthcare services from multiple types of medical care providers, specialists, and hospitals, then the complexity of the insurance organization can be avoided. They may want to be a purchasing group for those kinds of services that go beyond simple payment agreements between each member and their primary care physician. Concierge medicine, which began about 10 or 15 years ago, it operates in many areas of the country. And when it started operating, physicians started dropping out of insurance plans and offering their patients a monthly payment agreement for their medical services. They called this concierge medicine. The motives of the physicians seemed elitist. Reports were that doctors wanted patients to pay them substantial monthly fees for special attention in addition to using their insurance. The advertised concierge rates were more than $100 per month, or about 5 times as much as the health plans pay for primary care services. The fact that an individual can pay a physician a monthly fee for medical services that are not part of the insurance system is empowering to both the patient and the physician. A system of care and payment can be constructed, however, without the overtones of elitism. Such a system would be the backbone of a patient-physician cooperative. Now, this is how one of the cooperatives got started. Members of a nonprofit Christian organization in Houston incorporated in 2005 to provide members with healthcare services. The sponsoring nonprofit organization's income-producing work had been the management of contracts between physician groups and health plans, mostly Medicare Advantage plans. A consequence of that work was the organization had very detailed information about the cost and quality of care in the Houston area and was able to create a patient association that was both economical and supported by many qualified physicians and nurses. The association they created gave the cooperative proper governance and helped it recruit about 2,000 individual members. The cost of primary care services at the clinics was set at $30 per member per month on average. These fees covered the cost of the physician, staff, and overhead, and no additional fees were charged for services at the clinic. People who had Medicare and Medicaid could join the plan that contracted with the clinics and receive complete and comprehensive healthcare services, including prescription drug coverage for no premium. Employers could also buy a plan that contracted with the clinics and have comprehensive healthcare services at a reduced cost to the patient. Individuals without Medicare, Medicaid, or employer-sponsored health plans could join the clinics for primary healthcare services and use their health insurance to cover the specialty and hospital services that were required at other locations. The clinics also saw people who needed medical services, whether they could pay the monthly dues or not. In time, this first cooperative grew by inclusion of many individual primary care practices and the addition of payment plans with imaging centers, labs, telemedicine, and discounts from dental, vision, DMA, and hospital and specialists nationwide. It has become the foundation for a complete medical care system. It's designed by the people who use it and serve as the caregivers, patients, and physicians. This is a description of the cooperative as it now operates. The organizers find physicians who support the idea of a patient association in which the physicians can help and serve patients and mutually improve their health and well-being. Community organizers and physicians find people in the service areas of their practice who know their neighbors and who like to talk with them and help them. The physicians and nurses teach these people to be community health workers and teach them key skills in healthcare and public health so that these workers can teach others and thereby build membership in the cooperatives. People join the cooperatives to get health care from selected providers at fair and reasonable prices through retainer plans and fee-for-service.